Welcome to my presentation on ECT, TMS, ketamine, and the psychiatric mental health nurse practitioner role. To keep things as accurate and simple as possible, I decided to primarily use 3 literature reviews on each of the topics that will be discussed, and all 3 of them are directly from the UpToDate website. This is a reputable, paid subscription-only website that is utilized by physicians and other providers at UF Health and throughout the United States. And as its name implies, it is continuously being updated with data derived from evidence-based research. My hope for the audience is to bring about awareness and inform future psychiatric mental health nurse practitioners regarding these important, safe, and efficacious treatments that have the power to change the lives of the patients for those who are suffering with mental health disorders without adequate relief with other treatment modalities. Brief history. ECT began when observations were made in patients diagnosed with schizophrenia who often had a temporary improvement in symptoms after experiencing a spontaneous seizure. In 1938, an Italian psychiatrist used an electric current to induce seizures as a treatment for schizophrenia. ECT quickly spread around Europe and the rest of the world and was first used in the United States in 1939. During that time, patients suffered some adverse effects. But advances in anesthesia techniques in the 1950s allowed for the use of general anesthesia and muscle relaxation during the ECT treatments, which eliminated those problems. A simple explanation about the procedure itself is that ECT uses a small electric current to produce a generalized cerebral seizure under general anesthesia. The exact mechanism of action is unknown, but for the purpose of this lecture, I can share that human and animal studies show that ECT increases the release of monoamine neurotransmitters, serotonin, dopamine, and norepinephrine. Indications for ECT. Mainly, it is used to treat severe unipolar depression, but is also indicated for patients with other illnesses, including bipolar disorder, schizoaffective disorder, schizophrenia, catatonia, and neuroleptic malignant syndrome. ECT is generally not first-line treatment, but because it provides a rapid clinical response, it may be indicated as a first-line treatment in certain urgent clinical situations, such as severe suicidality, severe psychosis, catatonia, malnutrition in patients with food refusal secondary to depressive illness, and pregnant or lactating patients that are worried about teratogenesis can also be effectively and safely treated with ECT. There are no absolute contraindications to ECT. However, clinicians should be aware of the risks involved when using ECT to treat depressed patients with certain comorbid medical conditions. Patients with major depression typically respond after about 2 to 4 treatments. Disturbed sleep, appetite, and low energy may respond before mood, guilt, and worthlessness improve. It is estimated that remission occurs in 70 to 90% of patients who receive ECT based upon randomized control trials. For psychotic depression, ECT is particularly useful for psychotic depression, and ECT may be as effective or better in atypical depression, which is mood reactivity, hyperphagia, or increased weight, hypersomnia, latent paralysis, and interpersonal rejection sensitivity, compared with typical depression. And comorbid borderline personality disorder, it appears to be associated with decreased ECT efficacy. With regard to biomarkers, there's no biologic predictors of sufficient utility to identify which patients are most likely to respond to ECT. With regard to geriatric depression, reviews of numerous studies have found that ECT is efficacious and safe for geriatric depression. A retrospective study of medically ill geriatric patients with post-stroke depression found that ECT was effective and well tolerated for 90% of the participants. Research studies compared the remission rates of depression with ECT compared with imipramine and also compared with paroxetine. As you can see from this data, the results were that ECT was more effective at helping patients achieve remission rates than both paroxetine and imipramine. Next, I'll touch on safety. ECT is one of the safest procedures performed under general anesthesia. The mortality rate is at most 2 to 4 deaths per 100,000 treatments. Mortality is mostly related to cardiopulmonary events. Patients with coronary heart disease may be at risk for cardiac ischemic events because the seizure increases cardiac workload and oxygen demand. Concerns that ECT causes structural brain damage have been dispelled by multiple human and non-human primate studies. General medical adverse effects include aspiration pneumonia, fracture, dental injuries, headache, which is the most common, and nausea, which is transient. Cognitive adverse effects are acute confusion, anterograde amnesia, and retrograde amnesia. The acute confusional state is a result of the seizure itself and the anesthesia, and it typically resolves in about 10 to 30 minutes after the procedure. Anterograde amnesia typically resolves within 2 weeks after completing the course of ECT. Many patients report experiencing some cognitive effects during and after a course of ECT. However, objective tests indicate that neuropsychological impairment caused by ECT is generally short-lived, and impaired cognition due to depression typically improves after a course of ECT. Apprehension about the adverse effects on cognition, primarily memory, remains an impediment to prescribing ECT. However, the adverse effects of decompensated major depression and the potential benefits of ECT generally outweigh the potential memory loss from ECT. Reducing stigma. Stigma remains the absolute biggest barrier to the appropriate use of ECT. The level of knowledge about modern ECT among patients and medical practitioners is low. The portrayal of ECT in the media as a crude and coercive treatment remains problematic, frightening off patients who might benefit from it. One way the psychiatric mental health nurse practitioner can make a positive impact on this issue is by basing our patient education about ECT on current evidence-based research. Keeping ourselves properly informed and participating in open and honest discussions with other healthcare providers will contribute to reducing the stigma surrounding this safe and highly effective procedure, and hopefully leading to more favorable perceptions about its use. ECT has been portrayed incorrectly in the media, which has contributed to a great deal of stigma as well as misconceptions about its use, efficacy, and potential side effects. Patient advocacy groups and peer specialists with lived experience can facilitate the psychiatric mental health nurse practitioner in providing patient education and support efforts. The referral process will vary among the different providers and facilities, but the 4 key principles to keep in mind are, as new psychiatric mental health nurse practitioners, we will likely encounter patients that we know will require a higher level of care. We put our patients first when we are able to recognize that some patients' needs will be better met under the care of an experienced physician psychiatrist. And it is okay to ask for help. It is the position of the American Psychiatric Nurses Association that ECT is an evidence-based treatment for patients with severe depression and other serious treatment-resistant mental health disorders. ECT, when provided by properly trained clinicians, including specially trained and credentialed psychiatric APRNs, is a safe and effective treatment option. By 1820, scientists discovered that passing an electric current through a wire induces a magnetic field. This has become a common grade school science experiment where students wrap a wire around a nail and each end to a battery, turning that nail into an electromagnet. It was Michael Faraday in 1832 who discovered that the inverse was also true. Faraday showed that passing a magnet through a coil generates an electrical current, Faraday's law. The first attempts at TMS as a treatment for depressed patients were in early 1990. At a molecular level, TMS is known to have effects similar to those seen with ECT, which are increased monoamine turnover, increased brain-derived neurotrophic factor, and normalization of the hypothalamic pituitary adrenal axis. It is presumed that TMS exerts its effect on the brain through the activation of networks which in turn change gene expression, resulting in changes to the molecular environment of the central nervous system. The TMS machine. This is an example of one of many, but as with any device that advertises therapeutic benefit, the U.S. Food and Drug Administration, FDA, marshals control. The devices are regulated for general safety, and the companies can only advertise for approved disorders. In the United States, 7 devices have received FDA clearance for treating depression. The intervention uses a large alternating electrical current passed through a metal coil placed against the scalp to generate rapidly alternating magnetic fields and induce electric currents that depolarize neurons in a focal area of the surface cortex. TMS was first FDA approved for patients with treatment-resistant depression in 2008. Other indications for its use are listed here. And to add, obsessive-compulsive disorder is also currently FDA approved. The contraindications are listed here. Common side effects of repetitive TMS are headache and scalp pain. The headache and scalp pain can occur proximal to the site of stimulation. Topical lidocaine may reduce scalp pain, and some may require an analgesic such as acetaminophen or ibuprofen. An increase in auditory threshold, meaning hearing sensitivity decreases, can happen as well, and this side effect is transient, usually less than 4 hours. It is caused by the repeated clicks that are produced as the current passes through the stimulating magnetic coil. This can be prevented by having the patient use foam earplugs. The management of vasovagal syncope generally consists of reassurance, in addition to encouraging adequate hydration. TMS is generally safe and well tolerated and does not cause systemic side effects. The most serious adverse effect of repetitive TMS is a generalized tonic-clonic seizure. However, seizures are rarely observed and the risk appears to be comparable to that for antidepressant medications. Seizures probably occur in less than 0.1 to 0.5% of patients when safety guidelines regarding patient selection and stimulation parameters are followed. Other side effects are hypomania and mania have been described in randomized trials, as well as case reports of patients with unipolar or bipolar major depression who were treated with different types of repetitive TMS. However, the clinical significance is not known because patients with bipolar major depression can switch to mood-elevated states in the absence of an antidepressant treatment. Factors that increase the risk of seizures include personal and family history of epilepsy, such as a parent, sibling, or a child, pre-existing neurological disorders such as a prior head injury with loss of consciousness, prior brain surgery or congenital brain malformation. Medications that lower seizure threshold, some examples are bupropion, stimulants, TCA antidepressants, antipsychotics, and theophylline. Recent discontinuation of alcohol, benzodiazepines, or anticonvulsants can also lower the seizure threshold. And lastly, sleep deprivation. Special populations. For older adult patients with major depression, repetitive TMS can be beneficial if the stimulation intensity is sufficient. Depression frequently occurs after stroke, and repetitive TMS may help these patients. Although no randomized trials have evaluated repetitive TMS for pediatric depression with treatment-resistant depression, perhaps due to the risk of seizures, observational studies suggest that TMS may perhaps be beneficial. Pregnancy and postpartum depression. For these patients with major depression, small randomized trials and observational studies suggest that repetitive TMS may possibly be safe and effective. The summary of clinical use. TMS offers a non-invasive, safe mechanism to influence brain activity. TMS is FDA cleared for treating the acute phase of depression, with most work focusing on treatment-resistant depression. It is now also FDA cleared for treating OCD. There are also some trials suggesting the potential uses for hallucinations in schizophrenia, pain, tinnitus, PTSD, and addictions. Future work will involve establishing better parameters, intensity, duration, and location to enhance the effectiveness and utility of TMS. The role of the psychiatric mental health nurse practitioner in TMS is the same as with ECT. It's identifying higher acuity clients, being aware of your limitations, familiarizing yourself with reputable TMS providers, and knowing when to refer out.